All right. Hi, everyone. Welcome to the 95th session of Virtual Shadowing. Today's session is a nurse practitioner spotlight with Terry Warren. As always, you can reach out to us on Instagram at Virtual Shadowing or through our email, which is virtualshadowing@gmail.com. This session will be recorded and posted to our YouTube channel, which is Pre-Health Virtual Shadowing. Next slide, please. Here is the Virtual Shadowing Working Group, comprised of Taylor, Kiana, Elena, Shayan, Ali, Aditya, Christina, and Ashita, and myself, as well as our 4 physicians, Dr. Fowler, Dr. Salazar, Dr. Nguyen, and Dr. Reno. Next slide, please. Here are some of our upcoming sessions. So next week, we have a radiation safety expert. The week after that, we have patients dealing with chronic pain. And the first session for next month is a PA spotlight in plastic surgery. Join us on Zoom or YouTube Live at 7 p.m. Central Standard Time for these sessions. Next slide, please. If you could go to the next slide, please. Okay. And then, so as usual, we'll have 2 Q&A sessions, one near the middle and one at the very end of the presentation. If you have a question, please don't direct message it to either myself or the speaker tonight, as we may not see it. Please put it in the general chat so that our team can see those questions. This session will last about an hour and a half to 2 hours. And now for a few words from Dr. Fowler.
Welcome, everybody, to Virtual Shadowing. It's so good to have those of you who are returning back. Some of you are really quite devoted and tune in every week, and we're awfully pleased that you do that. We think that Virtual Shadowing provides the opportunity for you, the student who is in pre-healthcare, whether it's medicine, nursing, nursing practitioner, PA, or some other related field, to be able to have an opportunity to hear the words and see the lives of individuals who are devoting themselves to improving the lives of other people, regardless of what that part of the field will be. We have some exciting talks yet to come. We have a dermatologist coming. We have a radiation safety expert, one of my really close friends, who'll be talking about the perils of radiation exposure in this world today, especially with nuclear weapons. But regardless, we want you to know that we really appreciate you coming back week after week. We're going to add a little thing, which is it costs us nearly $10,000 a year, and I can break it down for you another time. We'll put it on the website. To run this, the Zoom account for $1,000 is $2,000 alone, and we give a stipend to our host each week for managing this. And so when you take the exam online, a new thing you're going to see is the opportunity. If you want to voluntarily make a donation, you don't have to. And it could be $1. $1 would be appreciated. The money goes to a nonprofit foundation that I established, and the money will be devoted toward expanding the Virtual Shadowing website opportunity and to keep these lectures coming for you, the pre-healthcare provider. We have an exciting guest tonight who I've known for a long time, both back when we both had color in our hair. And we have Rohit. Would you introduce our guest for this evening?
So tonight's guest is Terry Warren, a nurse practitioner, an adult nurse practitioner. She's also the owner of the Westover Research Group, where she sees patients through telehealth. And she's also participated in over 100 clinical trials relating to STIs and herpes in particular. Everyone, please welcome Terry Warren.
Thank you. Can you hear me okay?
Absolutely.
Yes, good. So they asked me to speak about how I got here, so I'll do that. Before I was a nurse practitioner, and there's a person on this team who has a similar route. I have a BA in psychology and a master's degree in counseling and a little cold. So I did that for a while, and I found that things just took a long time to get better, which is understandable, but I was impatient. And so, and I was getting a divorce. So I thought I would go to medical school. So I did all the pre-med, and during a break, I had a baby. And I remember distinctly sitting with her, nursing her, looking at biochemistry. And she would kind of pull away and look at me and, I say, get back on this nipple, please eat, I'm studying. And I thought at some point, wait a minute, this is not prioritizing correctly. So I decided to change the career to nursing. And so at 32, I went to nursing school. There I met one of my professors in microbiology whose area of research was gonorrhea. So we became close, and he and I ended up traveling to many STI meetings around the world in all these great places. And I just love the group of people that I was with. I think STI people are kind of crazy a little bit, but a lot of fun. And the meetings were always great and very educational. And so the relationship with the professor ended, but at the end of nursing school, I had a friend who was a nurse practitioner. And during nursing school, I did a rotation in the county STI clinic where we drew like 180 syphilis tests a day. I mean, it was this huge thing. And I just loved it. So I thought that people were there, but many of them seemed uncomfortable in the county health setting. So I decided, with a degree in nursing, that I would open an STI clinic, a private STI clinic, with this nurse practitioner friend of mine who had prescriptive authority. So we found an older house, rented the whole top floor in Northwest Portland, and opened a small clinic. From there, eventually I took over the clinic using prescriptive authority from a physician that was a friend of mine. Then I went back to school, got a master's in nursing, and was my own nurse practitioner with prescriptive authority. I found that the STI whole thing was interesting because it allowed me to combine the counseling picture with the nursing picture. So in 1982, opened this clinic. Gradually, through going to a number of different meetings, I became involved with the University of Washington. And the University of Washington and the University of Alabama and Birmingham are sort of the two hotbeds of STI research, particularly UW. And I became acquainted with some of the faculty there, specifically Larry Corey, who headed up the AIDS task forces where they ran all their clinical trials, but also very big in herpes, and Anna Wald, who's a dear friend, and also now head of infectious disease at the University of Washington. So eventually they asked, could my clinic run some clinical trials? So I hadn't really run clinical trials before. I didn't really know much about it. So I did some training in that area. And we started doing some small clinical trials with the University of Washington. What I found was that herpes in particular was a great combination with counseling. And Anna Wald and Larry Corey were heavily involved in herpes. So we started doing more with herpes research. I had hired physicians to be principal investigators on trials, but in the meantime was publishing quite a bit in New England Journal and JAMA. So I ended up petitioning the FDA to be the PI on my own studies. And the lawyers said, we haven't ever been asked that before by a nurse practitioner, but we'll review your credentials and let you know. So eventually they said, yes, you can do it. You have to have a physician as a sub-I, which was great with me because things come up in clinical trials that don't have anything to do with herpes. And my area of expertise had clearly been very narrowly focused on STI. So that was great. So we've done, at the clinic, we completed more than 125 clinical trials in various aspects of sexually transmitted infection, be that diagnosis, treatment, laboratory machines were brought into the clinic, vaccine trials. We did 4 herpes vaccine trials, all of which failed miserably. Gonorrhea, chlamydia, trach, you name it. We did those trials. It was a great experience. Ray asked me to talk a little bit about my family and how all that fit in. My family, I have 3 daughters. My eldest is a nurse practitioner like me. Second one is an assistant attorney general for the state of Washington. And our youngest has a master's in public health. So we've all kind of done the similar things. And I think it was really interesting having a mom who ran an STI clinic, because I get calls at 11 o'clock at night. Terry Warren, what am I going to do? I had this exposure and a condom broke and oh my God. So we'd meet down at the clinic and it was quite an experience, especially with our youngest daughter. So it was great and I loved it. But in 2016, I decided that enough was enough and that my husband and I really wanted to take some time to ourselves. We bought an Airstream trailer before that, and we had been camping a lot. So we decided to sort of take the show on the road. So I started seeing people with telehealth and very much focused on herpes simplex infections, which I was at the clinic when it was open. I had a staff of 24, but I was the one that focused on herpes the most. We had women's healthcare nurse practitioners, 2 physicians, a research staff. And at the time it closed, it was just enough for me. It was just like, the medicine was great. Managing people, employees was harder. So now what I do is telehealth. So I see anywhere between 18 and 22 patients a week, mostly people seeking herpes Western blots for confirmation of lab tests. And we're going to talk more about that because I think it's very important to know about. And the more people that know about the problems with this, the better. We're still camping a lot. We just got back from a boondocking rally, Airstream rally, where we gathered with 13 other trailers at a winery, tasted wine all day, hung out at night. It was great. So we're happy. And my dogs, I'm sorry, I have 2 Labradors who are playing in the background. So if you hear that, that's what's going on here. So I'd like to start with some true false. And I don't know that there's any way for us to measure who thinks these things are true or false. Is there any polling, Rohit, that we can do or not?
No polling, but we can ask people to put it into the chat and I can read out some of the chat messages.
Oh, that's great. So true or false, about 90% of the US population has HSV-1 infection.
So far, quite a few people are saying true.
Okay, that's false. Only 47% of the population between 14 and 47 has HSV-1 now, and that number has been steadily dropping. The older the population, the more likely they are to be positive. But for example, I had a patient today, a 45-year-old guy, wanted to know how common HSV-1 was in his age group, and I had that information. It's about 52%. So that number is steadily decreasing.
Terry, didn't it used to be as high as 70, 75%?
I think it was higher. Yes. And over the years, we've watched it all go down. And I think the reason that we've watched it go down is that more and more people are becoming aware that cold sores are caused by the herpes virus. And so they're more careful about kissing their children. The downside is that we have a whole group of adolescents who have no history of cold sores, and their first genital infection is HSV-1 from receiving oral sex from someone who is infected. Okay, the next one. 30% of women in their 30s in the US have HSV-2. True or false? We'll take a minute. Rohit can look.
Bit of a mix of both. People are leaning a little bit towards true.
And
Really, it's 50-50.
It is true. About 30% of women in their 30s have HSV-2 infection. And if we look at African-American women, the rate is much higher. This is a specific population with about 50% prevalence over that age group. And then by the time an African-American woman is in her 80s, it's about 85%.
No kidding. I didn't know that. Wow.
Yep. Men are more often.
Did you just say that?
Go ahead.
That elderly women in a certain ethnicity, 85% of them have genital herpes?
Mm-hmm.
Wow.
Well, have HSV-2 infection, which is almost all genital. Yeah. And we don't really understand exactly that phenomena, but it's there and it's disturbing. Dogs. Men are more often infected than women. True or false?
A lot of people saying false.
Correct. Women are more often infected than men by almost double. So if you think about it, you put a penis with lesions or viral shedding in a vagina, you rub it around really well with intercourse, vagina being one layer thick, the tissue, that's a much more likely event to transmit virus than a woman who has a lesion on the perhaps labia majora with a penis only approximating it during intercourse. I think you can see mechanically how that happens. Teens are getting HSV-2 more often than ever before.
50-50 on this one.
It's false. HSV-2 is definitely going down in teens. More people are infected with HPV than HSV-2. True or false?
Again, 50-50, a little bit leaning towards true.
Okay, so we're talking here about a difference between prevalence and incidence. So once you get HSV-2, you always have it, but most people will clear HPV. So HPV is more incident and HSV-2 more prevalent. So just a difference in how you define more.
Terry, I can recall years ago that as many as 40-45% of the population had a HPV, papillomavirus, wart virus infection on the genitalia. Is that still the right number, or?
I think the number now is 85% of people that are sexually active have had or have at least one type of HPV.
And the HPV, one or more, God, I'm so ignorant. One or more of the strains will clear, but there are strains that are more prevalent.
So most strains will clear, but 16 and 18 are more likely to hang around and cause cervical, anal, penile, and throat cancer.
You know, I was astonished, you know, as we talked earlier, I spent the first 20 years of my practice here where I'm sitting in Georgia, and we never saw cervical cancer. You know, it was a suburban population. They were highly screened and so forth. And then I went to Parkland, which is you know, it's a large indigent care hospital. And Lord, we see cervical cancer all the time.
which is virtually preventable with the vaccine.
And of course, it's the state of Texas where the governor, you know, has downplayed the importance, because if kids get the vaccine, of course, that means that they're going to screw around a lot.
Right, right. Because they're not if they don't get the vaccine, right? So I remember I used to travel on the road lecturing about herpes all the time. Maybe a third of my time was spent on the road when these herpes drugs were not generic, when they were still branded. And I remember going to a OBGYN clinic in Georgia or Alabama. I'm not positive which one, but it was this gorgeous office, and I met with these doctors over lunch, you know, to talk about herpes and stuff. And they said, we don't see herpes in our practice. And so it's like, okay, well, 80% of people that have this don't know it. And it's like, no, you don't hear me. We don't see this in our practice. So I said, okay. So the drug rep that took me there, she said, now we're going to go to a low income care clinic. And so we went, and they say, oh my God, we see this all the time. But these women will not go to their regular provider if they think they have herpes. They'll come here. And that's why they don't see it, because there's so much societal weirdness about having herpes. So I thought that was pretty interesting. Okay, IgM tests can sort out new from old herpes infection. True or false?
A lot of people are saying true.
It's absolutely false. Absolutely false. IgM tests are now, Mayo Clinic has eliminated it. Within the next 3 months, both Quest and LabCorp will take out IgM tests for herpes. They are not type specific. They are highly false positive, and the Center for Disease Control says never to use them. I can't tell you how many times I have had someone whose provider ordered an IgM test, told the patient they had brand new herpes. Patients believed they were in a monogamous relationship, but herpes testing was included for some annual exam. ruined their marriage, ruined their lives. And so thank God IgM tests are going away. Never.
And how many legal cases have occurred because an IgM test was positive and say, see, you gave that to me.
Yeah. Yeah. Well, we don't take those cases. There's other ones that are more interesting, but not that one.
Terry, this is crazy. I mean, you're turning upside down stuff I've been thinking for 35 years. You know, it's funny how medicine changes, isn't it?
Hope you don't mind. I mean, over my career, things have been turned upside down too, but this is a big one. Early use of suppressive therapy, that is medicine, herpes medicine taken daily, can delay seroconversion, can delay going from negative to positive on an antibody test. True or false?
About 50-50 on this one again.
It definitely can. So when you give somebody with brand new herpes, antiviral therapy starting right off the bat on a daily basis, you can delay seroconversion. I've had a patient be delayed for 2 years. So she was on 500 milligrams of valacyclovir for 2 years, had been told that she had HSV2 by PCR swab, but had negative antibody tests right along and didn't believe it, thought the swab was wrong, which it rarely happens. So I said, how long have you been on suppression? From day one. We pulled her off, and within 4 weeks, she was positive. So the deal here is that antiviral therapy, the purpose of antiviral therapy is to prevent viral replication. And if it's working really, really well, the immune system cannot see the virus to make an immune response called antibody. So when you see people in this situation, I think it's really important to keep this in mind about why somebody might be negative on an antibody test, but either positive on a swab test or unsure if they have infection. So in that situation, it's best to pull people off, and let's see what happens.
But the virus has still occupied their genome.
Yes. Yes. But it isn't being seen often enough. It isn't active enough for the immune system to make a response.
And so, at least from what I remember 20, 25 years ago, so they're on suppressive therapy. So maybe they're not shedding virus.
Maybe they're not shedding as much virus. Or maybe they're not shedding any, but I wouldn't say that, because we know that suppression only reduces viral shedding by about 50 to 70%.
See, you know, I started medicine 44 years. I started practicing 44 years ago. There was no treatment at all until finally acyclovir emerged. And
1982.
That's when it was. But when did it become really, really available?
I think around that time. I think Burroughs Wellcome had it, and I think around that time. And it's interesting about that because the woman who developed acyclovir, Gertrude Elion, won the Nobel Prize, both for that and some HIV drugs. But what was interesting about her, and I had the privilege of meeting her one time in a hotel breakfast place. What's interesting about her was that she was master's prepared. She didn't have a doctorate. And I think people treated her poorly. But she won the Nobel Prize with a master's degree.
How about that? I didn't know that. Yeah. So herpes won a Nobel Prize.
Herpes won.
As did HIV. I didn't know that.
Yep,
interesting.
She did. She was great.
Good for her.
So I think this is how patients view herpes, the end of the world, the scream. But this is how clinicians see herpes. At least some do. Let's not talk about it. Let's not go into that so much. But that's probably not a great response. So this herpes virus family, tonight we're just going to talk about herpes simplex virus 1 and 2, but there are 8 members of this family: varicella zoster that causes chickenpox and shingles, Epstein-Barr that causes mono, and it's becoming more clear it's related to multiple sclerosis as a cause as well. Human herpes virus 6 and 7 causes rashes in children like roseola and 6 disease. CMV, probably 95% of people have this, but if you're immunosuppressed, it's a problem. And HHV8, mostly in AIDS patients and Kaposi sarcoma. But tonight, we're just going to talk about herpes simplex virus. So who has herpes in the US, HSV 1 and 2? So about 48% of the population between 14 and 49 has HSV 1. We talked about that. That number continues to drop each time we look. And the way we look is through a study called NHANES, National Health and Nutrition Examination Survey, where we look at a number of characteristics of the population. And this is one of them. And the test that they use for the NHANES study is very good. Women are more likely to be infected than men, as we talked about. And we talked about the high rates of HSV2 in women, African-American women who have the same number of sex partners as their counterpart that are Caucasian. So the symptoms of genital herpes, you know, Rohit, whoops, I'm going to go back. I can't, these pictures make it hard for me to see the whole slide. Is there something I can do about that? Or
You mean the
like your
camera?
picture, my picture, Ray's picture?
There should be a minus sign. If you hit that, you can hide the thumbnail.
Got it. Thank you.
Terry, this is why I hang out with these kids. You know, I can't even start along.
Thank you very much.
But Terry, I did an Airstream trailer one time. Did you hear me? I had an Airstream myself one time. I'll tell you that story.
Really?
I did. I'll tell you the story sometime.
I'd like to hear it.
Okay.
So sores of genital symptoms, sores in the genital area that may start out as blisters, then break, form an ulcer, then a crust. They may be atypical, like cracks or fissures, red irritated areas, abrasions. What men in particular might cause friction burns, call friction burns. If the lesions are on the cervix or inside the urethra, they may cause a discharge. In women, that discharge is mostly like water. It's not yellow or white, it's mostly liquid. Outbreaks can occur anywhere in the boxer shorts area. So this is sort of waist to mid thigh, even behind the knee. Those are all herpes infections. Most infections are unrecognized. So about 80% of people that are truly positive for HSV2 don't know they have it. And that's a real problem. They have symptoms, the majority of them have symptoms, but they don't recognize those symptoms as being related to herpes. So men might think that they got their penis caught in their zipper, except that my husband tells me if you have it once, you don't do it again, and herpes is recurrent. Women might think they have a yeast infection or a UTI, so it hurts when they pee. Nobody does an exam. They're given antibiotics, they get better, but then they have a UTI again about 3 months later. And again, nobody's looking at them. They're just dipping their urine. Well, herpes lesions will dump white cells into a urine dip. So that's an important distinction to make as well. Okay, so Rohit, now I can't change the slide.
Oh, it's not letting you click forward?
Nope.
I think you go back, you click back to PowerPoint because you clicked over to Zoom when you made that change. Isn't that right, Rohit?
That should be it, yeah.
So what do you want me to do?
If you can navigate back to the PowerPoint.
Navigate back to the PowerPoint.
Let's see. How does she do this, Rohit? It's list. Your computer thinks it's talking to Zoom right now. Rohit, what's the best way for her to go?
Just try clicking on the screen. Does that work?
Oh yeah, it does. So what does the CDC say about all this? Just a minute. Hold on. Hal, can you get these dogs away? Thank you. I have this yellow lab puppy who's just terribly rambunctious. Okay, so the CDC.
This is what we call a rough evening.
It is. So the CDC says that the clinical diagnosis of herpes can be difficult because the typical presentation that we think of may be absent. So the clinical diagnosis should always be confirmed by a lab test. This is very essential. And both virologic swab tests and type-specific serologic tests for herpes should be available in clinical settings that provide care for patients with STDs or those at risk. So I think this is really an important point that we we cannot know for sure if people have herpes by looking at them. And we also can't know what type they have. I had a patient tell me today, my doctor says I have HSV1 because I only had 2 lesions. That's completely whacked. That's not true. You cannot tell by looking.
Terry, are you going to get into the relative percentages? Because people have genital HSV1.
Yes. Yes.
Okay.
In fact, most new cases of herpes in the US are caused by HSV1, not HSV2.
Being specific, most cases of genital herpes is caused, really? Most
Yes.
now?
Most new cases of HSV, of genital herpes are now HSV1, not HSV2. Most recurrences are still HSV2. Okay.
Interesting.
So for whom might an antibody test be useful? So the CDC guidelines have really clamped down on this, and this is because the tests are bad, but these are still people that you might consider getting a blood test for. People who have recurrent genital symptoms that are undiagnosed, someone who has symptoms suggestive of herpes with a negative PCR or culture, somebody who's been diagnosed by somebody looking at them and saying you have herpes, but no lab test was done and they don't have recurrences, a patient whose partner has herpes. So this number 5 is really being kind of reconsidered. People presenting for an STI evaluation really want to be tested for herpes, but the tests right now feel to me like they're getting even worse. So I think we should talk about maybe reconsidering this. People with HIV infection, if you give them antivirals for herpes, it helps to deal with their HIV infection. And men who have sex with men who are at increased risk of HIV infection.
Hey, Terry, in my world of a big urban ER, we see a lot of sexual assaults, and we actually have a sexual assault nurse, the SANE nurse, as you know, who deals with those. And one thing we don't prescribe is prophylactic acyclovir. Is there any reason to do that, or valacyclovir?
I don't think so, no. I think we know from the mouse model that if you infect a mouse and treat it immediately with antiviral therapy, that you can prevent some latency. But in the scenario that you're talking about, I think too much time will have gone by from the assault to treating prophylactically. But I would think that what would be very important is to make sure that that patient knows if they start getting any sores within 2 to 10 days that they should come right back in for treatment. So how do you diagnose herpes? Well, in the symptomatic person, you want to swab the area and look for virus. So if they've got any of those symptoms that we talked about, you want to look for virus. We used to do culture, but we've moved completely away from culture and are only doing PCR swabbing, gene amplification. Call it PCR, call it NAT testing. It's 4 times more sensitive than cultures. All major labs have PCR now, but it should never be done from blood. So an interesting thing goes on. So clinicians understand we're supposed to use PCR now, not culture. So they're doing it from blood, but herpes isn't in your blood, almost never. So it should only be done from swab tests, never from blood tests. 2 of my 18 patients today had PCRs done from their blood, which is $400 and a huge mistake. So not that. Culture swabs have a 76% false negative rate compared to PCR. So whenever possible, PCR swabs, not culture. So PCRs are very stable. They're not looking to grow anything. They're just looking for genetic material of the virus. You could put a vial for PCR on the windowsill here in the kitchen, leave it for 4 years and still be fine. So it's not
saying that if you actually take a swab from a broken blister and get the blister juice and you get virus on that swab, and reasonably know that there's virus on that swab, it's only going to grow out 24% of the time.
That's probably true. Yes.
Or you'll miss it.
Yes. I think the things that affect it are transport. That's a huge one. If you don't transport it correctly, you'll lose virus. Time to transport is another big one. Aggressiveness of swabbing is another big one. You have to be much more aggressive with culture than you do with PCR, because PCR is so much more sensitive and it's not looking for, large amounts of virus. A little virus will do. So there's a lot of reason to switch from culture to PCR. And I think that most people that I see when they present me with a swab test result are doing PCR. So we've got blood test on one side, swabbing on the other. On the swab side, we have PCR and culture. We want to get rid of culture and only do PCR. And when you do this with a patient, the swab is the same. The transport media is the same. It's what you ask for on the lab form that's different.
Terry, just to give you a little brain break for a second, you've got 212 kids listening to this talk right now from all over the world.
Good.
And you are speaking out to the future of healthcare here. And obviously from my blabbering over here, you can tell how many surprises I've just in the last few slides that I've heard from you. Because I remember, I was practicing before PCR came out, of course, and then cultures became available, and culture was sort of the gold standard. But these numbers are very sobering.
Yep. So how do you diagnose herpes in the asymptomatic person? You draw blood and look for antibody, but there are significant problems with false positives. So the two big labs in the US are Quest and LabCorp. I really want you to think about this. If you're not in the US, it doesn't really matter, but I'm sure wherever there are IgG tests, there are false positives. So the Quest IgG test is mostly done without inhibition assay. All the days that I see patients, today is the first day ever that I have seen someone who had an inhibition assay as a confirmation. And we have had in the past people doing inhibition assays that were positive and negative by Western blot, which is the gold standard. We'll talk about that. So, but without the inhibition assay, the Quest IgG, if the index value, which is a number that you get with the result, if the index value is 1.1 to 3.0, it's a 57% false positive rate. So we are sending so many people out into the world thinking they have herpes when they don't. And they know about this. They did the paper that showed this 57% false positive rate. So I think we've had some serious conversations with them. And I think it's really frustrating. LabCorp, the other big lab, they do an IgG test. And for confirmation, to their credit, they decided to do confirmation, but they use BioKit. So BioKit is an interesting little test where there's a little well, and you put a drop of blood in there that you either get from a finger stick or from centrifuge blood, and you put it in there. And if it turns pink, it's positive, and if it doesn't, it's negative. The problem with BioKit, and Dr. Rhoda Ashley Morrow at the University of Washington has documented this, and we've seen it in our clinic when we used to do this test. The BioKit often yields a pale pink background. When you see a positive, it's like, boom, it's this big, bright pink thing. But this pale pink shows up sometimes in the background. And LabCorp is calling that positive, which is a mistake. I just presented a paper at an HIV STI testing meeting, international meeting, looking at 44 patients who had positive supplemental positive IgG tests at LabCorp who were negative by Western blot. And some of them had index values as high as 6. So this is a really serious problem. And I think we have been speaking with them about this. I don't see too much shift. The other test that can be done is called an immunoblot. And an immunoblot is on the same platform as the Quest IgG test. And it should not be used as a confirmatory test because it presents with the same problems because it's on the same platform. It does not give an index value. So people that get this done don't know what their index value is. They don't know if they're in a low positive range and they should get a confirmatory test, or if they're like a 12 and they don't need a confirmatory test. So this test is also a problem. So as you can see, there's a whole lot of problems with routine available IgG tests, and it's just a real quandary right now.
Terry, this is not common knowledge. I mean, I'm in an academic institution. We deal with sexually transmitted infections. I've got 72 residents, and virtually nobody knows this stuff that you're talking about tonight. Very interesting.
It's really upsetting, don't you think?
Oh,
I just spend all of my days now, most of them. I would say, like today I had 18 patients, and I would say that 15 presented for Western blots, maybe 14. The other ones for counseling about HSV 2 or 1 or whatever. But yeah, they all had these tests. And I will tell you that in my practice, people who get Western blots, about 80% that were positive are negative by Western blot.
Terry, what about the change in levels on repeat tests? For example, the Quest test, you know, if you go from a 0 and you go to a pot, and you test them twice over a period of time, does that help at all?
So that's an interesting question. And the answer to that is that these tests can be used to document first infection. So if you see someone who has lesions and you do an antibody test at the time, they report never having them before. If you do an antibody test at the time and it's negative for HSV2, and 6 weeks later it's positive for HSV2 out of the low positive range, so higher than 3.5, combined with a positive swab test, that tells you that that person has new infection. So they have virus present on their skin, but not enough time has gone by for them to have made antibody. So in that situation where they go from a negative to a higher positive, you can document first infection. And that's the key to all these lawsuits that are happening. If you can't document that you were negative to start with, then you're dead in the water trying to sue somebody for giving you herpes.
What did you say was the sensitivity on the PCR?
We don't know the sensitivity of the PCR, didn't say, because there's nothing better. So we don't know.
So the specificity is close to 100%, but
yeah,
which means if you find it, that's not a false positive, it's real. But it may be there and you may not find it. So the sensitivity is not 100%.
The sensitivity is unknown. Yes, that's true.
Interesting.
For sure.
I feel like I'm back in school, man. Terrible. Except the curriculum has changed.
So let's talk about the Western blot from the University of Washington. So this is the gold standard. It's the criteria by which most people are entered into clinical trials to look at their herpes infections. And it's the only place in the US that does this test. So people ask me all the time, how is the IgG test different than the Western blot? And why is it so expensive? So with an IgG test, you put a drop of blood into a machine, and an hour and a half later, you get a result and an index value. With the Western, and it's looking for a single antibody protein that's different between type 1 and type 2. That's why it's called type specific. With the Western blot, each blot is read by 3 virologists or techs, and it looks for all 16 antibody proteins, and you have to have 4 of them present to be called positive. So it's much more comprehensive. It's 99% sensitive for HSV2 and 96% sensitive for HSV1. So when you compare IgG to Western blot, and I think I have a slide coming up about this, the IgG test misses 30% of type 1 compared to the blot and 8% of type 2 compared to the blot. So, and then you have the whole issue of false positives. So you have lack of sensitivity, particularly for HSV1, and then you have false positives for both 1 and 2. So it's kind of a mess. So with the Western blot, any clinician can call and get a kit from the University of Washington sent to them. This is in the US, but they've started doing it in Canada too with a special sort of something. The kit's free. The patient then needs to identify somewhere to draw and process their blood. So Quest and LabCorp both refuse, in spite of high rates of false positives, they refuse to draw blood for these patients to send to the University of Washington. They won't even draw their damn blood. So that's a real problem because those labs are everywhere. So patients are scrambling around trying to find some place to draw their blood. We've identified some chains. Any lab tests now and ArcPoint labs will do this, and they're kind of all around the place. They charge them about $40 to draw their blood. The patient needs to get a FedEx label online or at a FedEx store and then ship it back. The total cost, if there's no consult with me, it's about $350 to $400. So it's expensive. There's just no question about it. And it's inconvenient, but people will definitely do it because this is a lifelong, highly stigmatized infection. So the results on the blot are positive, negative, or indeterminate. There are no index values. It's just either the bands are there, they're not, or if one of them or two of them are there, it's called indeterminate. And an interesting thing about this is that indeterminates on the blot are definitely on the rise. And we don't know why. We don't know what protein is tripping. It's a specific band and it keeps coming up, and UW has to call it indeterminate. If someone gets an indeterminate, if they haven't had sex in a year, they should consider it negative. If they have had sex within the past year, then they need to redo the test 3 months from the first one. And if indeterminate again, they should consider themselves negative.
Is the virus mutating possibly? I mean, I'm not sure even what I'm asking.
I think there's just my opinion. I don't really know, but my guess is that people are picking up something else that has a similar weight protein that's tripping the IgG tests more often and tripping the Western blot. That's my guess. I don't know.
Or an inflammatory skin condition, eczema, or something. Who knows?
I don't know. But that's kind of disconcerting too. But mostly about 8% of my tests are indeterminate that I order. Okay, so let's talk about.
You said 8%, 1 in 12.
1 in 12.
Okay, all right.
7 to 8. So people don't make antibody right away, but the time, this is IgG testing now. So by 3 weeks from infection, 50% of people that are going to be positive will be positive. By 6 weeks, 70%. And by 4 months, most everyone who's going to seroconvert, and remember that the IgG test misses 8% of infections compared to the blot, most everyone will have seroconverted. And we talked about never using IgM tests, can't separate 1 from 2, can't separate other herpes viruses from simplex, and it's present in 35% of recurrences. In addition, in the case of herpes simplex virus, IgG and IgM come up around the same time. And IgM will show up again during recurrences from time to time. So best to take IgM completely out of your picture ever for herpes. It's different for hepatitis and other things, but for herpes, it's no good. So the CDC says never to use it. Now they've made that statement. So what does the CDC say about low positive index values? So they're saying anybody with an index value of 1.1 to 3.0 needs a confirmatory test, such as BioKit done well, or Western blot. So IgG misses 70% of infections in a screening population. So when people talk about what are the statistics of positive IgG, the sensitivity of IgG tests, the statistics that the companies use are how many cases out of people who have known herpes, that is positive swab tests, do the IgGs pick up? That's a very specific population. And that they say, oh, it's 98%, it's 96%. But the problem is, if you look at a screening population, people who don't have positive swab tests, the quality of the sensitivity and the specificity of IgG testing goes way down. So for type 1 in particular, it misses a huge portion of the population. And that's a problem. So why would you look for herpes by a lab test instead of telling somebody when they've got ulcers on their genitalia that they have herpes? Well, in terms of an STI screen, they expect it to be included. It's one of the most prevalent STIs. And when it's not included, then they don't know what to think, except that now the word is kind of getting out that the tests are poor, so they're not included very often. But then we're back to people who have herpes transmitting more because they don't know they have it. It's really quite a catch-22. It's the most prevalent STI in the US. Remember, incidence and prevalence are different. Identification can reduce transmission. So if you tell somebody accurately that they have HSV2, there are a lot of things that they can do about that. They can recognize symptoms, they can disclose to partners, and that disclosure increases the time to the partner getting infection. They can use condoms. Condoms reduce transmission by 96% from men to women and 65% from women to men. They can take daily antiviral medicine. So there's a lot that they can do if only they know they have it. So it can also clear up the misdiagnosis of other things like UTIs that are recurrently treated when people really just have herpes lesions in the urethra. It may reduce neonatal and C-section risk. And the problem is that when you're just looking and telling people they have herpes, they're wrong 20% of the time. So there's lots of reasons to use a lab test rather than just looking at somebody and telling them they have herpes. In addition, you can't tell what type they have by looking. So only a lab test can tell you what type. HSV 1 and 2 in a new infection or recurrent infection look exactly the same. Why don't clinicians test? I would say that false positives really should be number one. But another big reason is that they don't want to open this can of worms. They don't want to have somebody crying in their office. They don't want to have somebody asking all about oral sex and anal sex and what can I do and what can't I do. They don't know how to interpret a positive serology in the asymptomatic person. So if somebody's positive by Western blot, but they've never had any symptoms, clinicians don't know what to say. And I've had such wacky things. So I have had patients told that, oh, you've just been exposed. That's why you're positive. There's no such thing as exposure in relationship to this positive test. A person who has an accurately positive antibody test to type 2 should be told that you are both infected and potentially infectious to others, period. There's no other way around that. And, I think some clinicians just don't want to have to tell people that and upset them. But, we tell people you have cervical cancer, you have HPV all the time. I don't know. It's just not the same. Some clinicians don't believe that the test can actually sort out type 1 from 2. And there can be some cross-reactivity. In people with really high HSV1s, there can be some crossover to HSV2. So this is partly correct, but not so much. It's expensive for some people can be for some people who don't have any money. Some clinicians believe that everyone with herpes has symptoms. I can't tell you how many times I've heard, if you had herpes, you'd know it, except that 80% of people that are positive by antibody don't know it. Clinicians believe there's nothing to do about it, but clearly there's a lot to do about it. And they believe that HSV2 is often oral. That's not true. So HSV2 has what we call a very strong site preference for the genital area. And though we have seen people who have HSV2 both orally and genitally, that's rare. And HSV2 orally is not a happy camper. It doesn't like to be there. It doesn't recur very much, and it doesn't shed very much. So people could get it both places. They could give oral sex to and have intercourse with the same person and get it in both places, but doesn't happen very often. And when we take 100 people who have HSV2 accurately by antibody test, and we ask them to swab their genitals at home for 4 months using PCR. 95% of them will shed from the genital tract. So we know that HSV2 is primarily a disease of the genital tract. Ray, what do you think about these reasons why people don't test?
Some stories keep, I've been in practice so long. I had this guy back about 25 years ago. He's long dead now and no names given. The fellow, I had known his spouse who actually had anorexia and died of anorexia. I mean, the real deal. And so this fellow was now on his own again. So he went out and he was an old guy. And he went out and got lucky and proceeded to get this rash on his penis. So he came to the ER to see me. And I looked at it. I says, well, you have herpes. And he says, well, give me something to make it go away. And I said, it's permanent. And he went, damn. That's a true story. I think that the can of worms is absolutely right. The testing thing I mentioned about, I'm in an academic institution. And I'll tell you, so much of what you said tonight is not current knowledge. And so we have a long way to go. The serology interpretation, I bet I could go touch 10 people and ask them about IgM, people that know about herpes, and they would say that, well, that's a reliable test for if you just had an infection. The expense is for real. Now I'm in an indigent population where people mostly, it doesn't matter. We order whatever we want, and we kind of don't worry about it if the patient can't pay for it, because it's sort of absorbed into the county hospital routine. But in suburbia, in the normal world of folks, the expense is a real deal. And even if they're insured, having just seen my own dentist, Terry, and having a tooth fixed, and getting billed a fair amount of money, I have dental insurance, and the dental insurance paid about 1/10 of the bill. So expenses come from a lot of directions. And plus, you talked about the facial herpes. I came into this program thinking 75% of people had type 1. And I learned from you tonight that is not so. I also thought, I seem to remember from 20 years ago that we thought we saw an increasing incidence of HSV2 in the mouth, with also a coincident HSV1 occurring genitally. And you taught me tonight about what you said about the HSV2 doesn't really like to be dormant in the nerves of the face, I guess, is what you just said.
Yep. Well, thank you, Ray. I appreciate your insight on that. So we've been talking for about an hour. Rohit, do you want to do the thing that you do?
Q&A, sure. We can do that now. We have a couple of questions already.
I'm going to go pee. I'll be right back.
Oh, okay.
Well, that's wonderful. Well, while we're waiting for the break, any of you need to go pee, go do that. I may get a Diet Coke, and then I'll go pee. So in chat, what do you think about this discussion so far? I've known Terry a long, long time. I got to know Terry when I was working on a project called Herpes.org about 22 or 3 years ago. It was a subject I became interested in, and I started researching it. And then I read the researchers who were working on it. And I got to know Terry, and it has been an interesting ride getting to know some of these great folks, Anna Wall in Washington, and some of the vaccine researchers around the world also. While we're waiting for Terry to come back, I put a note in chat a while ago talking about venereal disease, talking about sexually transmitted infections. You are going to see these folks unless you end up being a radiologist and you're away from patients. If you're in family medicine or emergency medicine, if you're a urologist, as a surgeon who works on the genitalia and kidneys and so forth, these are patients, number one, you're going to see. And I hope that you see tonight about, Terry is one of the most informed people on the planet Earth about this subject. I'm bragging on you, Terry. And I'm telling the students, Terry, that just about anywhere in medicine that they're going to be confronting patients, they're going to have patients who deal with this, and just how remarkable it is that how the science continues to evolve on this. So why don't we move to, and by the way, I put into chat to say, what do you think so far? We got a lot of feedback saying a lot of information. Very interesting, and so on. So very. So good. Rohit, take it away.
Okay, so we have a few questions for you. One thing is, why would you start a patient on suppressive dosing versus treating when they're symptomatic?
Good question. So there are two answers to why someone would go on suppression. The first is to have fewer recurrences, and the second is to reduce transmission to a partner. So antiviral therapy taken daily reduces transmission by half. That's a huge thing to be able to offer when you are a patient with herpes and you are attempting to have a sexual relationship with someone who tests negative. By the way, I would suggest testing in that situation, just to determine that people are indeed discordant. That is, one's infected and the other is not, rather than just assuming that they are. So those are the two situations in which you would use suppression. Now, if let's say that somebody's HSV2 positive, they aren't very bothered by their recurrences, or maybe they don't have very many, and they're not sexually active, they don't need to be on suppression. If it doesn't bother them, there's no reason to, until they meet someone with whom they would like to have sex. And then they should start suppression 5 days before planning to have sex, because it takes that long for the antiviral therapy to be maximally effective. So that's my answer to that.
Thank you for sharing. Another question. If a person doesn't have an outbreak, will their STI blood test come back negative because the viral load is low?
No, that's not how that works. No. So the viral load, that's a concept that's really HIV related, not herpes related. People who have herpes always have virus around, and whether they have an outbreak or not, they still have virus around. So no, that would not cause an antibody test to be negative.
Terry, let me follow on to that. Of folks who develop genital herpes, HSV2, what percentage of them, small, medium, or large, never have a symptom? They're infected. They could be shedding virus, but they've never shown a symptom. What percentage would you say?
20%. So we know that 80% of people that are infected with HSV2 are not aware of their infection. And of those, only 20% actually don't have symptoms. When you tell somebody that they have HSV2, in our study with Anna Wald, Anna in my study said that once you identify people as being infected, by 6 months out, the majority will identify an outbreak. Only about 20% of people can't identify an outbreak once or symptoms consistent with herpes, can't identify an outbreak at all.
One time when I was working on the website, you may or may not recall, I used to answer questions for people writing in. I did thousands of those, thousands. And one gal wrote in and said, I only have a little small lesion on my butt. Does that mean I don't have it in my vagina? Would you comment on that?
Yes, I'd be happy to. And that's a great question also. Buttocks herpes is genital herpes. So what we know is the people who only get outbreaks on the buttocks, those outbreaks tend to last longer. The outbreaks come through more heavily keratinized skin, so they take longer to heal. They scar. And 25% of the time, they will be shedding virus from the vagina or penis. Those people will also shed asymptomatically from the genitalia, even when they're not having an outbreak. So I think it's important that we tell people, this is just so ironic. I'm sure you don't know this. So I was camping 2 weeks ago with this couple that we know, and my husband's laughing. And I'm sitting in their trailer, in their Airstream, and she's talking about her cold sores and she's kind of a really sweet, kind of a bit naive woman. I like her very much, but she said, I get these things on my butt and they just come and I put some acyclovir on them or I take some pills And they take about a week or two to go away, and then they just go away. But they're really annoying. And I've told my doctor about it, and he said, don't worry about it. And her husband is sitting next to her. And this came up because I'm talking about my career with herpes. So clearly she has genital herpes. And he looks at me and he mouths, don't tell her. Don't go there. Because I think he recognized it, but would know that she would just be devastated. And they've been married for 50 years. So needless to say, I didn't. But yeah, I think buttocks herpes gets confused with, is that genital herpes? Is that not? So does that help answer that question?
Yes.
Any other questions?
Let's see. Let me look at the list, Terry, 2 seconds. Yeah, we've covered this, but let's end this part of the session with this. Why do providers order the wrong tests? I can already tell what your answer. We talked about this, but why do the providers order the wrong tests? And I guess you could add.
They don't know any. They don't know any better, or they are functioning on information that isn't up to date. That's why. That's what I think. What do you think? I mean, why would you order the wrong test?
Well, this is a field that obviously I've dabbled in now for a long, long time. And you've already taught me things. I mean, hell, I'm a professor in a medical school and you taught me things and I didn't know. And I know my colleagues don't know. And so
I need to come down there and talk to your colleagues.
Well, would you like to do that?
Sure.
Sure.
But then we deal with this whole thing about, I'm not going to learn from a nurse practitioner. So, I mean, we can talk about it.
Terry, you could make taking a laugh moment for a moment. You could have made a career once you got so smart in herpes on legal consulting. One of our toxicologists, who's a great lady that actually we trained her, and then she went on to become a faculty member in our toxicology, is half-time, and she spends the other half-time doing legal consulting and casework and court work all over the country.
And I do some of that too. But
oh,
not
do you? Well, there you are.
I definitely do. Really interesting cases. I mean, I'm involved with 3 of them right now, and they're really interesting.
All right,
okay,
keep going. This is
all right.
Are you
Here we go.
okay? You need a water? Or are you doing okay? You're
I'm
good.
No, I'm good.
All right.
So if you're going to do herpes serology, what codes can you use to get it covered by insurance if they don't cover STI screening? So these are some symptoms that people with herpes might have that you can use as a code to hopefully get it covered by insurance. By the way, the University of Washington, thank you, does not bill out-of-state people's insurance for the Western blot, only people that live in Washington. So my whole practice is cash-based. Oh, there it is. And we already did it. So why do we want to know the type? Why is it important that every single time we diagnose somebody with herpes, we have to know the type? Well, the source is different. So most HSV1 is oral to genital transmission. And as oral sex becomes more common, more accepted, more expected, that's why we see that most new cases of new genital herpes in the US are type 1, not type 2. This can happen in a completely monogamous couple. I distinctly remember a young couple that came into my clinic. They were Mormons and they had been on their honeymoon and she came back with this raging case of genital herpes. And she was savvy enough to know that it was probably herpes. She said, he told me he was a virgin. Now he lied to me. Now I have genital herpes. And it was just a mess. So I asked, did he give you oral sex on your honeymoon? And apparently that was not something that was supposed to happen, but it did. And so she told me that it did. And I said, let's not jump to any conclusions here. He's sitting in the room. I didn't have sex with anybody else. I never have. So swab test PCR positive for type 1, not type 2. And this allowed this couple to go on and understood why this happened. He didn't know, he had cold sores. He didn't know that he could give off virus from his mouth when he didn't have a sore. So that kind of cleared that up. So whenever you're dealing with herpes, you're never dealing with just a medical issue. You're always dealing with a psychosocial, psychological, emotional, societal thing that's going on here. So the
Terry,
yeah.
Terry, that what was that percentage you gave for the protection for herpes given by condoms?
96% reduction of transmission from men to women and 65% from women to men.
And then if you combine that with suppressive therapy with valacyclovir or acyclovir,
50% reduction. So now you've got numbers that are incredibly low.
So you're talking 99% protection, maybe something like that.
Something like that. Yep. The trick is that condoms need to stay on, be used regularly, and not break.
Now, what if about symptoms versus non-symptoms? What if the male has blisters but uses a condom, and then also but is taking suppressive therapy and happens to have an outbreak on suppressive therapy? Is there still a substantial reduction? Apparently so.
Well, I think that we would tell people who have symptoms never to have intercourse when they have symptoms, because condoms break and they come off. So, it's a calculated risk if you just can't wait, that the condom may underperform. So that's why we tell people not to have sex with symptoms, at least not intercourse with symptoms. So the prognosis, go ahead.
No, please go ahead.
So the prognosis is different. HSV-1 after the first year recurs about every other year, or HSV-2 recurs an average of 3 to 5 times per year. And HSV-1, if you don't have a recurrence in the first year, there's an 88% chance you'll never have another one. So HSV-1 genital infection is a far more benign problem than HSV-2. But if you have HSV-1 genital infection, you could subsequently acquire type 2. We don't know if there is any reduction in the ability to acquire type 2 if you have type 1 genitally. We haven't studied that.
Terry, what is the reduction for people who go on suppressive therapy, just taking a Valtrex once or twice a day or whatever the dose is? What is the reduction in the HSV-2 outbreak rate from the 3 to 5 times per year? Is it reduced?
About 70%. And transmission is reduced by 50%. So there are other factors involved in transmission than just reduction in recurrences, because people can virally shed without any recurrences. That's why that number is different.
I remember from 20 years ago, the work that I think you were involved with that talked about the reduction of viral shedding with the use of suppressive therapy. Could you comment about that?
Yes, I mean, we reduce viral shedding by 70 to 80% with antiviral medicine. And most that's been studied is valacyclovir 500 to 1,000 has also been studied. But it's very effective for both genital and oral infections. So it reduces viral shedding, it reduces recurrences, and it reduces transmission. And that's another reason that people who have herpes should know, is that they can then intervene with antiviral medicine. So it's a real problem when the test sucks and you don't want to use it, because if you did use it, you could really help people identify their infection and reduce transmission. So the tack that I take, and I'm privileged in the setting that I work in because I can deal with people that can afford it, but if I've got patients that are positive on their IgG test, and I've had patients with an index value of 17 not confirmed by Western blot, and there's an interesting paper about that in 2020. If they're positive by IgG but they have no recurrences, I Western blot them, because I'm seeing these people with these high now index values, especially immigrant populations, Russia, India, Africa, of course, have higher rates of false positives. So it's a problem, because you want to tell people if they're infected or not, but the test isn't good. The routine test.
I have 2 questions. Having a herpes lesion, if one were careless enough to have intercourse, with that and the blister breaks makes you more likely to pick up yourself something, perhaps pick up HIV?
Yes.
Because
So
you have.
yes, we know that about 30 to 40% of the HIV epidemic is directly related to HSV2. Because what happens there is that you have a break in the skin, and the cells that come to defend against a herpes outbreak are the very cells that HIV prefers to infect. So you've got this, I envisioned it in my mind as this little car with this particular kind of T cell in it, that you get a herpes outbreak, the T cell activates, the little car comes down to deal with the herpes infection, but there's HIV sitting outside. So HIV just gets in the cell, takes the car back to the whole immune system, and there you go. So we know that those two epidemics, if you will, are closely related.
What about long-term toxic effects of suppressive therapy?
We're not worried about that. We have long-term data. And as, I don't know if you know Hunter Hansfield or Ned Hook, but those are both long-term STI guys. And Hunter is known to say these nucleoside analogs are safer than aspirin. So the way a nucleoside analog works, in my very rudimentary understanding of this, is that they first of all, they have to be activated in the presence of a viral enzyme. So if there's no herpes enzyme present, they just get excreted unchanged. If there is herpes enzyme present, they get activated, and the virus takes up this medicine, this nucleoside analog, thinking that it's one of the nutrients that it needs to replicate, but it's a phony. So the medicine gets put into the DNA chain, but it can't replicate anymore because it's not what it needs. That's a very rudimentary way but it helps me to think about it that way.
Terry, what about increasing resistance, or is there any of HSV to a cyclovirus Valtrex?
No.
Really? I did not know.
It stayed pretty even at 0.3% of strains. And we see equal amounts of resistance in people who have taken antiviral drugs and in people who have not.
Interesting. Because I had thought from a generation ago that there was some concern for increasing resistance, but that's very, very low.
I think there's always concern about could it happen, but we're not seeing it, not to my knowledge.
I've been reading with interest. Excuse me. I've been reading with interest and I bet you have too, these treatments for COVID. And, you know, Paxlovid, I believe, is a protease inhibitor, but molnupiravir from Merck is a chain breaker, as I understand, but apparently is quite a bit more toxic. I mean,
I don't know anything much about that, honestly. I mean, I know what I would ask for if I had it, but I don't know much beyond that, I'm afraid.
Yeah. I bring that only in the context. It's interesting that acyclovir Valtrex is so safe for so long. But well, anyway, are you going to get into the issue of women who may be pregnant and have intercourse with someone who may be a herpes carrier? Are you going to talk about that?
I think that's in here, and if it's not, you can remind me, and I will talk about it.
Yeah, please keep going. Please.
Okay. So we also want to know the type, because susceptibility to the opposite type is different. So if you have HSV2, I think the chances, and this is Zane Brown's work at the University of Washington looking at pregnant women, ironically, if you have HSV2, the odds of getting HSV1 subsequently is something like 1 in 50,000. However, if you have HSV1, it does not protect you against getting HSV2. But what it does do is keep a new HSV2 infection subclinical or with more minimal symptoms, because the antibodies are similar, that you get some protection from a wild outbreak if you have HSV1 first. And the most people that don't know they have HSV2 are people that have HSV1 first.
Can people have both HSV1 and HSV2, have them both in the genital area?
That's rare, but it has been documented for sure. Yes. It's not common at all. Your treatment choice may be different. So we might choose, if we have a positive lab test result, to suppress someone with HSV2 early on to avoid more trauma, emotional trauma, to reduce transmission to partners. But it may not be necessary for new HSV1 because it doesn't recur very often and doesn't shed much. Why do
So Terry,
yeah.
I've heard the discussion before. Well, you know, you're in a relationship, you're monogamous, and you have herpes. Just let your spouse go ahead and catch it. And I've had that expressed to me in a clinical setting before. Do you have any comment about that?
Well, what I would say about that is that couples make this decision on their own, and some couples will be fine with that. But with a divorce rate of 50%, I think most couples would like to reduce the risk of transmission by doing practical things. I think some couples will start out doing everything they can, using condoms and taking antiviral therapy. And maybe after their relationship becomes more stable, they stop using condoms and just rely on antiviral therapy. So, but I think we have to consider pregnancy. I think we have to consider divorce. I think we have to consider the emotional stigma in making that decision. And I just give couples the information and say, you guys make the decision. I'm not you. I can't decide for you. I would say if pregnancy is a consideration in a young couple, that if you're going to do that, if you're going to intentionally or just not take precautions and get herpes, it shouldn't happen. It shouldn't happen later in the pregnancy. If you're going to do it,
So,
get it in the first trimester.
all right. I'm sorry. Would you finish that last sentence? If you're going to do it.
If you're going to intentionally avoid doing things to reduce transmission, do it in the first trimester, but don't do it in the second and third trimester, because that's when the mother's immunity begins to wane. She's becoming more immunocompromised, and she's unable to mount much of an immune response of her own. So the risk of her infecting her child is greater. So the baby at most risk is the baby born to either a woman who doesn't know she has HSV2 and isn't doing anything about it, or a woman who acquires either HSV1 or 2 genitally in the third trimester.
Different subject or related subject. If you have a couple and they both have herpes, will you put them both on suppressive therapy?
Not to reduce transmission, but if one of them is bothered by their frequency of recurrences, then yes.
Okay. Good stuff. Keep rolling. You doing okay? You hanging in?
Oh, I'm fine. Why do 80% of people infected with HSV2 not know it? I think the main reason is that most herpes infections are subtle, not dramatic. Outbreaks can occur in the entire boxer shorts area, as we discussed. People attribute their symptoms to other things. Providers are misdiagnosing herpes as shingles. Either they're doing that intentionally or by mistake. So I've had so many people tell me, I'm getting my shingles outbreaks about 3 times a year, and I just wonder what I can do about that. It's like, we need to talk about this, like my woman in the trailer, because we didn't talk about it. But I think sometimes clinicians paternalistically decide that they're not going to upset people. And I think they tell them they have shingles. And then people are really, at some point, confused about, why do I have shingles 4 times a year and everybody else only gets it once and 4% of the population get it a second time? I mean, what's going on here? So I think I wouldn't tell somebody that they have shingles if I know they have genital herpes, but I might, in the situation of my friend in the trailer, might not go into it more, because what are they going to do about it? I mean, she's with her husband 50 years. They're totally happy. They're taking a cruise around the world. There's no point, but I wouldn't tell her she had something else instead. And then we talked about HSV1 infection ameliorating HSV2. But another reason is that people aren't being tested. And as we talked about, that's a complicated situation.
A question just popped up in chat that I'll go ahead and share with you, which was, why would physicians intentionally diagnose herpes as shingles?
So that they
And
don't stigmatize people. But
okay, that's one reason.
The bummer about, well, either that or they don't know that shingles is not a recurring disease in the healthy adult. Only 4% of people ever get it a second time. So I think
I would add another to that. I'm a faculty in a training program. I've had 500 residents come in the 21 years I've been there. I think dermatology is one of the weakest areas in my world of emergency medicine of physician training. But anyway, please go on.
So these are just some slides, and this is a slide of a woman. This lesion that's circled by the blue was swab test culture positive for HSV2. You can see that it's very small, and if you had not been investigating the flap of the labia, you would never have seen it. But this patient said this area feels different, and this was culture positive for HSV2. So people will talk about paper cuts and wonder if paper cuts are herpes. But as you can see, this is a little wider than a paper cut. I had a patient today ask me about paper cuts. And I said, they're a little wider than paper cuts herpes lesions. And I think this is a perfect example. This is recurrent buttocks herpes, which is genital herpes. You don't really see any scarring on this bottom, but often if you have them back away from you with their butt towards you, you'll see scarring, and that helps you to know what's going on here. This is anal herpes. So anal herpes is also genital herpes. And this is a person who had this outbreak, and a man, and he said, but I don't have anal sex, I'm straight. So he says, why do I have this here? Because the herpes virus lives in the sacral ganglia, and it can come out in any branch of that ganglia that it wants to. It can be on your butt, on your anus, on your thigh, on your belly, or on your genitalia. It's all genital herpes. And
can you talk?
yes?
Well, go ahead. I have a follow-on once you're done with this.
So this is herpes on the thigh. You can see that these are vesicular lesions on a reddened base. This person said, well, I don't have thigh sex. I mean, how could I possibly have gotten this here, whatever thigh sex is? But this is a case of the virus traveling along a different branch of the sacral, coming out of the sacral ganglia. And this is genital herpes.
Well, can it go all the way to the tip of the toe?
I have seen a herpes lesion on the back of an ankle, but only once. But conceptually, yes, that's the innervation.
Well, I guess that's what a whitlow is. That's what we use the term for, sort of a non-genital or non-lip presentation, like on the finger. But a herpetic whitlow on a finger is due to direct transmission to the finger.
Yeah.
Okay.
Yeah, that's different than the virus traveling along a different. Yeah. And then. Sorry.
Go ahead, please.
This is herpes.
No, please, I want to interrupt.
This is herpes in the urethra of a male. So this guy may have a lot of pain with urination. And if you look inside the urethra for a quick peek, you can see this lesion. Most often these are accompanied by external lesions as well, but not every time. So if you've got a guy with pain with urination, and this is pain during urination, so you have acid urine passing over this open sore, that hurts. It's not pain at the end of urination, which sometimes men describe. This is one that would hurt during urination. So Ray, did you have a thought here?
No, I was going to follow on with a question about neuralgia when you finish up.
Okay, I'll just finish these pictures. Oh, we're done with that. So what about neuralgia?
Yeah, so there are people that I've seen that have nerve pain that often in the absence, it can be a what's the word I'm searching for? It can be a sign that they're about to develop an outbreak.
A prodromal sign?
Prodromal is the word I was searching for, yes.
Yeah. Yes,
And so
it can be a big problem for some people.
And as you say, it can be sort of anywhere in the pelvic region. So anyway, please go on.
Most commonly down the back of the leg, however. And people that are really plagued by this, gabapentin could be tried to help relieve that. So what is the frequency of viral shedding? So just to be clear, viral shedding is giving off virus from the body, and it can happen with or without symptoms. So for HSV-2 genital infection, people who have symptoms shed virus on about 20 out of 100 days. So if we're doing daily home swabbing, where we're capturing what's going on with them, their own natural history, we find that it's about 20% of days in symptomatic people and about 10% of days in asymptomatic people for people with genital type 2. For people with HSV-1 oral infection with recurrences about every other month of cold sores, they shed virus on about 1 out of every 4 days. For genital HSV-1, in the first 6 months, they shed it on about 13% of days. After 6 to 8 months, it's about 7% of days. And after they've been infected for 2 years, they shed virus on about 4 days out of the year. HSV-2 oral infection, about 1% of days. So these viruses definitely have their site preferences. This slide. Go ahead.
That's a new thing for me. I thought facial herpes shedded a lot more than that, even when they were asymptomatic. And you say if someone's got facial herpes dormant, it's only shedding 3 days a year when you say 1%. So it doesn't shed much.
You're talking about HSV-2 oral infection, but I'm talking about, up here is HSV-1 oral infection, which sheds quite a lot.
Okay.
Yep. So this slide, I want to talk you through it. So I've got all this stuff at the top of my slide. Is everybody seeing that or just me?
We got it.
Okay, so you can see the top of this slide?
Yes, ma'am.
Okay, so this is a person who did daily home swabbing for 160 days, and they were their own control. This is a crossover design. So
this is PCR or it's not culture?
It's both. It's both. So I'll just explain the slide. It's a rather busy slide, but I'll talk about it. So on the top of the slide, there's, the first 80 days, the area under the pink is when she was on placebo. So the blue vertical bars are swabs that were taken from PCR swabs taken from the cervix, and the yellow ones are PCR swabs taken from the vulva. On the lower part of the slide, you can see some pluses. Those are days when she was culture positive. So you can see that there are many more days where she's PCR positive than culture positive. And then you can see the horizontal bars. Those represent days when she had a lesion. So for example, this stuff is screwing up how I can see it, but so she had an outbreak from day approximately 28 to 32, 31, 32. I don't know what it is. But so she had positive cultures on that day, and she had 1 million copies isolated from her vulva. And so you can see, like on day 20, she had a positive culture, 1 million copies. I think it's 1 million copies. I can't see the top of the slide. From her cervix. And you can see that she really sheds virus a lot before an outbreak comes. That's her pattern. So then again, she has an outbreak on day 46 through 53 with shedding lots from her cervix and vulva. Then here on day 60, she's still on placebo. And you can see that she sheds 1 million copies from her vulva, no outbreak at all. And then on day 70, she has an outbreak, but not much shedding. So what you see is not what you get in terms of viral shedding. And you can see that even when she doesn't have any sores, she's shedding 1 million copies. Then moving down to the second part of the slide, you can see that on the top, it's green. So that's what we call a washout period, which means that she's continuing to do placebo. Then on day 90, she switches to 400 milligrams of acyclovir BID. And you can see the dramatic decrease in viral shedding. Is it perfect? No. Does it take a little while to kick in? Absolutely. But you can see that the shedding has dramatically changed. So these drugs work really well. But I think it's also important to note that, again, what you see is not what you get. Just because you're having an outbreak doesn't mean that's the only time you're shedding or that you're shedding at all. But it's complicated, as you can see. Do you have any questions about this slide?
So the take-home point on the lower portion of the slide is that 400 milligrams of acyclovir taken twice a day. And by the way, while we're talking, I went to GoodRx to see what the going price was at Kroger, and it's like $30 for 90 days or something. It's dirt cheap.
Yeah.
And so taken twice a day from day 103 to 149, there was no viral shedding that could be identified.
That's right.
On a drug that, as far as we know, is essentially harmless, I guess, unless you're allergic to it.
Yeah, which is extremely rare.
Right.
So it's a very, I think, a very impactful slide in a lot of ways that you can see, one, how sensitive PCR is compared to culture. How many more vertical bars are there compared to pluses? What's the shedding like before outbreaks in this person? And how well acyclovir works. So what are the transmission rates in established couples? So when we do studies, we don't have people meet in a bar and say, hey, my name's Hank, I have herpes, do you want to do a clinical trial with me? I mean, these couples have been together for a while. So we're, in essence, looking at, to some degree, survivors, people who have not transmitted early on. But that's the only way we can really look. So the conditions of these transmission statistics are that the couple is aware that one has herpes, the other does not. They agree to abstain from sex with outbreaks. They're not using condoms regularly, and they're not taking antiviral therapy daily. This is in the group that isn't taking daily antiviral therapy. So the rates of transmission on average, and these are averages because studies vary quite a bit, on average about 10%, and having sex about twice a week. So on average, about 10% of men will transmit per year, and about 4% of women will transmit per year. Some studies show more, some show less. So that when people ask, how likely is it that I'm going to get this? I think we need to be aware of these numbers so that we can help couples make reasonable decisions about how likely it is to transmit. And one of the things that I say to people is, when you're nervous about disclosing this information to someone else, first of all, you're not a bad person because you have herpes. You're a good person because you're disclosing. The other thing to keep in mind is that everybody brings some shit to a relationship, right? You could be drinking too much. You could be too close to your mother. You could be cheap. This is a thing that you bring that's not great, but everybody's got not great. This one is manageable. This one is visible. But I think we don't want people getting into a one down position because they have herpes when they're telling someone new. But this information is important to be able to share, I think. So how do you reduce transmission? We've talked about this. Antiviral therapy suppressively reduces transmission by 48%. We've talked about condom use. We've talked about disclosure and avoiding sex while symptomatic. So we talked about this too. HSV2 triples the risk of HIV acquisition. And we talked about how that happens. And it's very important, was particularly important when the HIV epidemic was looking worse. So who benefits from suppression? I think someone who has an uninfected sex partner is the big one. Another group is people who have multiple sex partners and maybe aren't disclosing this to everybody. I had a patient today in the afternoon. I always say, how many sex partners have you had in the past? How many, if any, sex partners have you had in the past 3 months? Because we want them to wait 12 weeks from any concerning sexual encounter or unprotected sexual encounter to do the Western blot for greatest accuracy. He told me he got on his phone and he counted. He'd had 9 unprotected sex partners in the past 3 months. And he tested positive for HSV2 by immunoblot, so we don't know what his index value is. So this man would be, if he tests positive, really positive by Western blot, he would be somebody who would benefit from suppression, because I would suspect after talking to him that he's not going to disclose this, but he could go on suppression and use condoms and greatly reduce the risk of infecting someone else. Somebody who has new genital HSV2, who has already been diagnosed by lab tests, so we know they're infected. We know that in the first 6 months, people are most contagious, often shedding up to 42% of days. Women late in pregnancy, so women with genital herpes, either type 1 or type 2, who are late in their pregnancy, immunocompromised by the pregnancy, their shedding is increased. And the dose for them should be double what the dose is for the non-pregnant person.
Also non-toxic to the fetus, as far as you're aware.
Yes, yes. And then also people who are at higher risk for HIV acquisition, maybe MSM, or people with, again, with multiple partners, and anyone who wants to have fewer outbreaks. And I am not the adjudicator of how much is too much outbreak for people. They can decide that for themselves. This is a safe medicine. And if they have 2 outbreaks a year and it's too much for them, I don't care. That's fine. It's a safe medicine. So, who may not need suppression.
Terry, if they say you're so safe, why isn't it sold over the counter? Narcan that we give for opiate overdoses is now sold over the counter now in 48 states. I checked that yesterday.
That's a great question. I think that is probably driven by multiple factors, one of which, a huge one is economics. For the people that had this drug branded, they wanted it prescribed, not over the counter. Now that it's generic, I'm not as sure. I think we also don't want people we want people to know that they have herpes before they're taking this medicine so that they can do additional things to reduce the risk of transmission. But I honestly don't have the perfect answer about why that is.
Terry, you mentioned that the facial herpes HSV1 rate has dropped considerably. A relative reduction is about 30% from 75 to 50, plus or minus. What would you say has been the change in HSV2? You touched on it a while ago, but just a quick comment over, say, the last 5 or 10, 20 years.
It's coming down, not as dramatically as HSV1, but it's definitely coming down. And I have those statistics. I'm not going to go there, but it's definitely coming down. And I think suppression plays a role in that. I really do. I think that the patients that I deal with, when I tell them that they have HSV2, they immediately want a prescription to reduce the risk of giving this to other people. So I think that's...
I tell them, put the bottle by where your vitamins are and take them both every day.
There you go. I think that's great advice. So someone who might not need suppression are people who have HSV, but they're not sexually active at the moment and they're not bothered by their outbreaks. Someone whose partner is infected with the same type, we're not worried about that. And if they're not worried about outbreaks, they don't need suppression. And couples who've made the conscious decision not to worry about sexual transmission. So these are people that may not need suppression. Some patient counseling messages. I think these are messages that can be given in a short period of time, but are essential messages for someone with new herpes. And I cannot tell you how many people tell me that their provider sent them a note and said, you have genital herpes. I can phone you in a prescription. And that is it. That's it. They don't know. They don't say any more to them. So I think these are some things that you can say easily. You are still the same person you were before you had this diagnosis. Many people have lived with it for years before they got diagnosed. They're not different. They're the same. They have a viral infection that they might not have had before. You can still have children. You can still have sex, but you really need to make people aware of this, both from a ethical and a legal point of view. You can transmit virus between outbreaks. This is probably the hardest news for people, is that there isn't a day that you can say to your partner, today I know I won't infect you, because we don't have that day. There are effective treatments. We would like better. You need to give yourself time. It's not going to feel better tomorrow. It might take you 6 months to feel better, but you will feel better. The people that don't do well are people with OCD. They have a very hard time with herpes, and people with already present anxiety disorders in general struggle a bit more. I think it's important that we let patients know they can come back and talk to us. I say to people, make a list, write it down. Before we meet next time, I want you to have this list in your hand, and we'll go over things one by one, and we won't feel rushed, and we'll just take our time. And you can bill for that. You can bill for extended visits and get paid for it, so it's not a loss financially. Antiviral therapy, you can look at this. I think first episode, you want to treat everybody. You don't need to wait for a lab test. Just start it. There's no downside. If they don't have herpes, well, they're just going to pee it out. But important to give a refill. Episodic therapy is treating outbreaks as they come up. So you can do acyclovir. There's a whole raft of things you can do. So acyclovir 3 times a day for 2 days, or famciclovir 1 gram twice a day for 1 day, or valacyclovir 2 grams. I love this one. Valacyclovir 2 grams orally, then 12 hours later, 2 grams again. That is the FDA approved dose for cold sores, but I've also found it works really well for people with genital herpes outbreaks. And then suppressive therapy, acyclovir 400 twice a day, famciclovir 250 twice a day. Why anybody would do famciclovir? Well, I shouldn't say that, but generally speaking, if you're going to do a BID drug, do the cheap one. Or valacyclovir 500 once a day, or valacyclovir 1 gram once a day.
What about acyclovir 800 taken once a day?
Not effective. Not enough to slow down suppression. So I've had people say, I can stop outbreaks with 800 milligrams once a day. And I say to that, great, good for you. But if you start having sex with somebody who's uninfected, that's not going to cover transmission risk. Acyclovir just doesn't have enough bioavailability to do that. Just doesn't. It's only 15% versus 55% for valacyclovir. Another thing to think about is if your population is African American, you really want to stay away from famciclovir because it's nowhere near as effective. Just a little thing we know about. Okay, that's it for me.
Wow, Terry, what an amazing discussion. You have 226 people online with you, and not a single one is left. You had them riveted.
Thank you. Thank you.
Oh, just marvelous. Terry, I want to share this with you. This popped over and then it said, please take this for the context it's in. Nursing practitioners don't get enough credit. All doctors should be thankful for them and learn from them too. I am so happy I'm getting the opportunity to learn from you, Terry. And we part of the context of these discussions is so that these are not just pre-med, pre-PA and so forth. These are students that are considering their careers. And the fact that you have been an astonishing leader of a very important industry affecting as much as half the population that can affect in a moribund way people's feelings about themselves is just, we've been so astonishingly benefited by hearing you tonight, Terry. And I
make me cry. Thank you.
Oh, stop. Okay, go pet the dog. But go get in your Airstream. I'm going to send you a picture of my Airstream, by the way. Okay. I don't have it anymore. I actually gave it away. I'll tell you the story when I talk.
Oh my God, they're worth so much money now.
Oh Jesus, I know. So, Rohit, let's give her 2 or 3. Terry, you up for 2 or 3 quick questions?
Absolutely.
And then
Are we going to do the quiz now or do we do it not now?
So the quiz will be later.
Okay.
Yeah, we'll send them we'll actually give them a link to the test question, so you won't have to do that.
Okay.
So rock and roll, Rohit.
Okay. Do we know the average amount of virions that it takes to make a naive individual infected with HSV?
Great question. Great question. So we think it's 10 to the first for a neonate and probably 10 to the third for an adult.
Wait. 10 particles? 10 to the 1 is 10
No.
viral.
Yes. So a neonate is incredibly susceptible. So this work comes out of the University of Washington. And this is Zane Brown's work. So they were swabbing all the women who had herpes and delivering babies, and then looking at the babies that got infected and how much virus was present in the female. So 10 to the first for a neonate and 10 to the third for an adult. Of course, it doesn't really matter because you're never going to know what it is. I mean, there's no, at any given time, except for these women and babies that were in this study, for an adult, you're never going to know how much you're shedding at any given time. There's no technology like that. We don't even have, if we had technology, if we had rapid PCRs, it would be first applied to OB so that we could swab a woman when she's getting close to delivering and say, is there virus here? Okay, she can do a vaginal delivery. Or if there's virus here, no, we're going to do a section. You know what I mean? But we don't have the ability to do that on a routine basis.
We can do it on group B strep, or we could, but not for herpes. Interesting.
PCRs take, and I'm not a laboratorician, but I would say at least 3 hours to do a PCR.
And the shedding could change hour to hour, I guess.
Shedding could change. So people say, isn't there a test that I could swab my genitals right before I have sex and know if I'm, and that'd be great. But depending on how long you have sex, you could start shedding during sex. So I think the OB application is the only practical one.
One or two more, Rohit.
Okay, then just one more. So you mentioned previously that providers might not fully disclose about herpes. Will this still apply in the case of a pregnant woman?
Oh, that's a really great question. So I have a story about that. So I was, again, in the South doing a luncheon talk to this OB practice, and there were all women in the room that are, auxiliary staff, nurses, front desk people, whatever, and one OB male. So I was I advocate, and I'm not in the mainstream, that if I were pregnant, I would want to test to know if I had herpes, because I wouldn't want to take a chance of infecting my baby. I'd want medicine at the end of my pregnancy. I mean, to me, it just seems like such a slam dunk. But anyway, I was advocating that. And well, people were asking, like, why aren't we testing our pregnant women? It was like, I don't know. Why aren't you testing pregnant women? And this physician who was eating lunch was so angry with me that he just started spitting food. It was like, why would you ruin a perfectly wonderful pregnancy by telling a woman she had herpes? And I did not bite my tongue. And I said, why would you ruin a perfectly wonderful baby by not knowing that she had herpes? I mean, it's controversial. I'm well aware of that. But many OB practices do test women. So here's the deal. If you have a woman who's positive for HSV2, accurately positive, she should be observed at the time of delivery for lesions. If she has them, she should be sectioned. She should have double the dose of suppression from 34 to 36 weeks on. And then if she has nothing, she can have a vaginal delivery, because those women who are already infected and know that they are pass antibodies to their babies in the last part of their pregnancy.
And these antibodies are protective?
What?
And the antibodies are protective?
They're helpful. They're not 100% protective, but they're very helpful. So women who have established disease rarely infect their neonates, especially if they're being cared for by somebody who knows anything about herpes. The women that are problematic are women who get infected, as we discussed, in the third trimester of pregnancy. So if I were running an OB practice, I would test the woman. And if she's negative, I would test her partner. And I would say, here's why we're doing this. And Zane Brown did it for years at the University of Washington, testing both members of a pregnant couple. And so let's say that the woman's negative for 1 and 2, and the partner's positive for 1. What would you say? Don't give her oral sex in the last part of the pregnancy. And that's pretty common because as bellies get big, intercourses get harder. And so oral sex becomes more common. But what you don't want is a guy or another woman, whatever the couple is, giving oral sex to this pregnant woman and giving her HSV-1 genitally at the end of the pregnancy, because intercourse is awkward if it's a heterosexual couple.
Does HSV-1 infect a baby differently than HSV-2?
Yes. So HSV-1 proportionately infects more babies, but HSV-2 is a more serious infection. So we have 3 types of infections in the neonates: skin eye and something else, and then disseminated infection and neurologic infection.
Sure, exactly. Encephalitis and so on. Well, Terry, this is magnificent. Click to the next slide, which I think is pretty close to our last slide. And Rohit, you want to take that away, then turn it back to me?
Yeah, so this is the quiz information for session 95. Here's the QR code, which you can scan, or you can also use this link. The link is also posted in our Zoom chat, and it'll also be included in our weekly email, as well as on our website, which is virtualshadowing.com. You have 1 week to complete the quiz. It's due just before the next session starts. You have 2 attempts to score at least a 70% or better to get the certificate. And please remember to download the certificate.
I'm kind of bummed we can't discuss the quiz because I had some things in there I'd like to discuss, but I will accept this.
Well,
I know it's not usual.
I don't care. I got nothing but time. What do you want to do?
Let's
the thing is, they've got to actually take it and pass it to get the certificate. That's the problem.
Okay.
We
won't discuss it.
All right, don't pout.
I will not pout. I'm not a pouter.
All right, Terry, I want you to look at the chat now, and I want everybody to put "Thank you, Terry" into the chat, all 210 of you, and just watch these things pop through from all over the world. Is this wonderful or what?
I can't see the chat. But
oh, you can't see it. 200 "Thank you, Terrys" are coming in on chat right now. So.
Well, thank you very much for your graciousness and for being invited. I'm delighted to be here and to see you again, Ray.
Well, Terry, I just want you to know that we're going to put your talk online. Probably 5,000 people will watch it, pre-healthcare students. Each one of them will have a career, and during a career, they will see probably 100,000 patients. 5,000 times 100,000 is 500 million. Terry, tonight, you've touched 500 million lives. And so
thank you.
We're so deeply honored, educated, and inspired by your enthusiasm, your grace, your humanity. Just what a wonderful, wonderful talk. Well, everyone, on behalf of our speaker this evening and the Virtual Shadowing Working Group, we want to thank you for coming. I think this was a riveting presentation. And we will see you next week for yet another in a series of great talks. And so on behalf of Terry Warren, I call her Dr. Warren, on behalf of Terry Warren, Doc Warren, and the whole team, we wish you